Hi, my name is Laura, and welcome to my audio version of the Internal Medicine, Orthopedics, and Rheumatology EOR Study Guide. The rest of the internal medicine topics can be found on my channel, but I'll link them below as well. This review is going to follow the PAEA, Orthopedics and Rheumatology portion of the Internal Medicine End of Rotation Exam topic list, and I'll timestamp all the topics below in case you'd like to skip around. The first topic is fibromyalgia. And this is a condition of widespread chronic muscular pain, fatigue, headaches, poor sleep, and memory problems. It's most common in middle-aged women and can be associated with hypothyroidism, rheumatoid arthritis, or sleep apnea. The cause of fibromyalgia is unknown, but it might be due to an increase in pain perception in these patients. Symptoms include diffuse pain, especially in the morning, extreme fatigue, stiffness, painful tender joints, sleep disturbances, difficulty concentrating, and symptoms that can get worse with stress. Diagnosis is made clinically if the patient has diffuse pain in 11 out of 18 trigger points that lasts more than 3 months. A definitive diagnosis is made with a muscle biopsy, which will show a moth-eaten appearance and muscle damage. Treatment for fibromyalgia includes exercise, stress reduction, and other lifestyle modifications. Pharmacotherapy includes antidepressants like duloxetine and anticonvulsants like pregabalin. The next topic is polymyalgia rheumatica, which is an idiopathic inflammatory condition that affects the joints. It's more common in women and in patients older than 50. Polymyalgia rheumatica causes synovitis, bursitis, and tenosynovitis, which results in bilateral proximal joint aching and stiffness, predominantly in the shoulders and the hips. And stiffness is particularly prominent in the mornings, with more than 30 minutes of stiffness, making daily activities like brushing the hair or putting a jacket on more difficult for these patients. And just note, this condition does not present with muscle weakness. Weakness might be a sign of another condition. Also, it's closely associated with giant cell or temporal arteritis. The diagnosis of polymyalgia rheumatica is mostly based on clinical presentation. Labs will show an elevated ESR, and they can have a normocytic anemia. And if there's concurrent giant cell arteritis, that can be diagnosed with a temporal artery biopsy. The mainstay of treatment is corticosteroids. Patients are started on a low dose of corticosteroids, and they should improve within a few weeks. By 3 to 4 weeks, there should be significant improvement, and their inflammatory markers, like that elevated ESR, should be reduced. If there's no response to steroids, consider another diagnosis. Other medications that can be considered for polymyalgia rheumatica include NSAIDs and methotrexate. Next is polymyositis, which is a rare idiopathic autoimmune disease that results in chronic inflammation of proximal muscles. This causes symmetrical, often painless, progressive proximal muscle weakness, typically of the shoulders, the hips, abdomen, upper legs, and upper arms. Other symptoms might include muscle atrophy, polyarthralgias, and dysphagia. Patients are going to have an increased creatinine kinase and aldolase enzymes, increased ESR, and an abnormal EMG, or electromyography, where they record the electrical activity produced by skeletal muscles, like an EKG for your biceps. Polymyositis is associated with anti-Jo1 and anti-SRP antibodies. Anti-Jo1 antibodies are specific for myositis, which includes both polymyositis and dermatomyositis. Anti-SRP antibodies are specific to polymyositis. Ultimately, a muscle biopsy of an affected muscle is the definitive diagnosis. And treatment consists of high-dose corticosteroids as first line. Immunosuppressants like methotrexate or azathioprine can be prescribed as well. Polymyositis is sometimes confused with dermatomyositis, so let's review that here too. Dermatomyositis presents similarly to polymyositis with the proximal muscle weakness and inflammation, but it has inflammatory and degenerative skin changes too. Heliotrope rash and Gottron's papules are pathognomonic for dermatomyositis. A heliotrope rash is a bluish-purple discoloration of the upper eyelids, and Gottron's papules are violaceous, raised, scaly eruptions on the knuckles. Dermatomyositis is associated with anti-Jo1 antibodies, the myositis-related ones, as well as anti-Me2 antibodies, which are specific for dermatomyositis. It often causes an increase in creatinine kinase and aldolase levels, and a diagnosis is made with a biopsy. Treatment is topical corticosteroids and often oral corticosteroids for the myopathy. Immunosuppressants might be prescribed as well. Also, these patients have an increased risk of malignancy, so cancer screening is important in dermatomyositis. Next is Polyarteritis Nodosa, which is a type of vasculitis, or inflammation of the blood vessels, that affects medium-sized arteries. Polyarteritis nodosa occurs when immune cells directly attack the endothelium, confusing it with hepatitis B virus, which is why this condition is associated with hepatitis B. This causes transmural inflammation, affecting all layers of the vessel, the tunica intima, media, and adventitia. Inflammation causes these layers to die, and then fibrosis occurs as the vessel wall heals, a process called fibrinoid necrosis. But because the vessel wall is now weakened, it's prone to aneurysms, which are pretty common in this condition. So arteries develop these fibrotic aneurysms that present as hard bulges down the length of the artery, and they look like a string of beads on an angiogram. So as we said, polyarteritis nodosa affects medium-sized arteries, which typically supply organs. So organ ischemia is the main complication. If the renal arteries are affected, hypertension can occur due to increased renin, as well as renal failure. If mesenteric arteries are affected, abdominal pain and GI bleeding can occur. If arteries supplying the brain are affected, neurological symptoms can occur like amaurosis fugax, peripheral neuropathy, and mononeuritis multiplex, which is a type of neuropathy. If dermatologic arteries are affected, symptoms can include livedo reticularis, purpura, ulcers, gangrene, nodules, and Raynaud's phenomenon. Also, polyarteritis nodosa typically spares the lungs. Treatment is centered around decreasing the vessel inflammation, and first-line therapy is corticosteroids. Cyclophosphamide can be added if it's refractory, and plasmapheresis can be initiated if the patient is positive for Hep B. The next topic is rheumatoid arthritis, and this is a chronic, systemic, inflammatory disease with persistent symmetric polyarthritis of small joints, bone erosion, cartilage destruction, and joint structure loss. So basically, these patients present with pain and stiffness of the hands and feet bilaterally, often with the MCP or metacarpal phalangeal joints, the PIP or proximal interphalangeal joints, MTP or metatarsal phalangeal joints, eventually the wrists, ankles, and even shoulders and knees as the disease progresses. And again, it's symmetrical, so both sides equally. And it gets worse with rest, so RA or rheumatoid arthritis patients wake up with joint stiffness that lasts about half an hour in the morning but improves throughout the day. This is in contrast to osteoarthritis, which actually gets worse throughout the day with continued use. So these stiff joints get swollen, tender, erythematous, and another word that's used is boggy joint. Rheumatoid arthritis also presents with a prodrome, which includes fevers, fatigue, weight loss, and anorexia. There are a few specific joint deformities that occur as RA progresses, and these are probably good to remember for exams. A boutonniere deformity is flexion at the PIP joint with extension at the DIP joint. So basically, you can't straighten the middle joint of your finger with this deformity. A swan neck deformity is the opposite, so hyperextension at the PIP joint and flexion at the DIP. So it does kind of look like a swan neck, I guess. Another deformity is ulnar deviation at the MCP, or metacarpal phalangeal joint. These patients are also more prone to Baker's cysts. What happens is that fluid from the swollen knee fills the semimembranous bursa and causes the synovial sac to bulge posteriorly into the popliteal fossa. Manifestations of rheumatoid arthritis outside of the joints is mostly due to inflammatory cytokines and can include fever, malaise, weakness, and low appetite. This is that prodrome mentioned earlier. Another manifestation is development of rheumatoid nodules in the skin, which are collections of macrophages and lymphocytes with a central area of necrosis. They typically occur at pressure points like the elbow, but can present in other areas too. There's an increased risk of atherosclerosis, anemia, interstitial lung fibrosis, and pleural effusions. Rheumatoid arthritis typically affects women more than men, and smoking is a known risk factor. Diagnosis is made by blood test. The best initial test is rheumatoid factor, which is sensitive but not specific. The most specific test is anti-cyclic citrullinated peptide, or anti-CCP antibodies. These patients also have increased CRP and ESR. Diagnosis might be suspected clinically by a presentation of arthritis in 3 or more joints with morning stiffness that has lasted more than 6 weeks, or even presents with anemia of chronic disease. The main X-ray finding in rheumatoid arthritis is narrowed joint space, as well as decreased bone density and bony erosions. Symptom control is managed with anti-inflammatories, so NSAIDs are first line, and corticosteroids are second line for pain control. But the cornerstone of treatment for RA is prompt initiation of DMARDs, or disease-modifying anti-rheumatic drugs, which will reduce permanent joint damage. First line is methotrexate, which is often used as monotherapy for RA, and other options include hydroxychloroquine and sulfasalazine. Biologic agents are another option, and these in general target cytokines or the receptors or are directed against surface cell molecules. Reactive arthritis, also called Reiter syndrome, is an autoimmune response that occurs after an infection, often a sexually transmitted infection or gastroenteritis. STIs like chlamydia and gastroenteritis pathogens like Salmonella, Shigella, Yersinia, or Campylobacter are all gram-negative, so they have liposaccharides on their surface. These molecules are also known as endotoxins, and they produce a strong immune response. The mechanism of reactive arthritis is related to how these liposaccharides interact with class 1 major histocompatibility complexes, also called MHC1 molecules. Most patients who develop reactive arthritis have the specific gene HLA-B27, which codes for the immune molecule MHC1. The HLA-B27 gene is associated with 5 inflammatory diseases: reactive arthritis, psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease-associated arthritis, and undifferentiated seronegative spondyloarthropathies. And these diseases as a group are referred to as seronegative spondyloarthropathies. They're all autoimmune inflammatory joint diseases that are seronegative, meaning that there is no rheumatoid factor present on labs. But testing for the HLA-B27 gene will often be positive. Okay, back to reactive arthritis. Symptoms normally start a few weeks after an infection, and typically only the joints are affected. However, other tissues can be involved too, including the urethral lining and conjunctiva. This triad of arthritis, conjunctivitis, and urethritis is referred to as Reiter syndrome, but it's not that common. But the memory hack for the reactive arthritis triad is can't see, can't pee, can't climb a tree. Okay, so arthritis is the most common symptom, and it typically presents as pain and swelling of a single large joint, like the knee. Also, rarely, patients can present with Scleroderma blennoragicum, which is hyperkeratotic lesions on the palms and soles. Diagnosis is made by a history of infection, clinical exam, and positive HLA-B27. And arthrocentesis of synovial fluid will show a negative bacterial culture, meaning it's aseptic. First-line treatment is NSAIDs for the pain and inflammation. If there's no response, methotrexate or sulfasalazine can be tried, or steroids. And if the patient still has a precipitating infection like chlamydia, treat with antibiotics. The next topic is gout and pseudogout. Gout is an inflammatory disease characterized by the accumulation of monosodium urate crystals in the soft tissue, joints, and bones. It's most commonly due to underexcretion of uric acid. Gouty attacks are secondary to purine-rich foods like alcohol, red meat, organ meat, and shellfish. These foods cause rapid changes in uric acid concentration. Attacks can also be secondary to medications, like thiazide and loop diuretics, ACE inhibitors, pyrazinamide and ethambutol, which are tuberculosis drugs, aspirin, and ARBs, except for losartan, which actually decreases uric acid levels. So let's talk biochemistry for a minute. Purines are a component of nucleic acids, like DNA and RNA, and when they're broken down in the body, purines are converted into uric acid. Uric acid can be filtered out of the body and excreted by the kidneys in urine. But when it's in the body, uric acid is not very soluble in bodily fluids, and when it exceeds its solubility, we get hyperuricemia. Uric acid in the body then loses a proton and binds to sodium, forming monosodium urate crystals. So in a gouty attack, hyperuricemia leads to monosodium urate crystals being deposited in joints, and the joints become red, hot, tender, and swollen within hours. Acute gouty arthritis is often seen in just a single joint, most commonly the first metatarsal phalangeal joint in the great toe, which is called podagra. Knees, feet, and ankles are also common. Repeated gouty attacks can lead to destruction of the joint tissues, resulting in arthritis. Tophi, which can occur after 10 to 20 years of chronic hyperuricemia, is the formation of permanent deposits of urate crystals along the bones just beneath the skin. Hyperuricemia can also affect the kidneys, causing uric acid stones, glomerular nephritis, and even renal failure in severe cases. Diagnosis of gout is made by arthrocentesis, which shows negatively birefringent, rod or needle-shaped urate crystals. Also, a serum uric acid level will be greater than 8, but this alone is not diagnostic. You have to actually do the arthrocentesis. And x-rays will show rat bite or punched out erosions. Treatment includes dietary changes to decrease purines, so avoid too much red meat, organ meat, shellfish, and alcohol. NSAIDs are the drug of choice for acute attacks, specifically endomethacin is first line, but avoid aspirin since it can increase that serum uric acid. Colchicine is second line, but it has a lot of GI side effects. And steroids can be prescribed if other meds aren't enough or if the patient can't take NSAIDs. In the management of chronic gout to try and prevent acute attacks, allopurinol is first line. Allopurinol reduces uric acid production by inhibiting xanthine oxidase, and it increases uric acid excretion. It can also cause some GI irritation though, and it has to be used with caution in patients that have kidney disease. Also, allopurinol should not be started in an acute attack. Wait until after the attack has subsided. Another option for chronic gout is febuxostat, which is safe in kidney disease patients. Colchicine can also be used in chronic as well as acute gout treatment. And if the patient is also being treated for hypertension, consider using losartan for that, since it decreases uric acid levels. Now on to pseudogout. Pseudogout resembles gout because it causes red, swollen, tender joints, but it's most commonly the knee or other large joints. It's caused by calcium pyrophosphate dihydrate deposition in the joints. Diagnosis is made by arthrocentesis, just like gout, but pseudogout will show positively birefringent, rhomboid-shaped crystals. You can remember this because pseudogout starts with a P, and so does positively birefringent. Treatment is intra-articular corticosteroids as first-line therapy, followed by NSAIDs. Colchicine can be used again both for acute attacks or prophylaxis. So let's review. Gout is caused by monosodium urate in the joints and is most common in adult men, while pseudogout is caused by calcium pyrophosphate dihydrate and is most common in elderly women. Arthrocentesis in gout shows negatively birefringent needle-shaped crystals in the synovial fluid, while pseudogout will show positively birefringent rhomboid-shaped crystals. Gout occurs most often in the great toe, called podagra, and is typically monoarticular in the lower extremities. Pseudogout can occur in the knees, wrists, elbows, MCP and MTP joints. Acute gout attacks are treated with NSAIDs as first line and colchicine as second line, and possibly corticosteroids. Chronic gout is managed with uric acid lowering agents, most commonly allopurinol. Acute pseudogout attacks are treated with intra-articular steroids as first line, and second line is NSAIDs and colchicine. Chronic pseudogout is managed with NSAIDs or colchicine as well. The next topic is Sjogren Syndrome, which is a chronic inflammatory autoimmune disorder that targets exocrine glands, like the salivary and lacrimal glands. This causes the symptoms of xerostomia or dry mouth, keratoconjunctivitis sicca or dry eyes, and parotid enlargement. Sjogren syndrome is divided into primary and secondary. Primary occurs alone, while secondary is associated with other autoimmune disorders. Additionally, there's an increased incidence of non-Hodgkin's lymphoma, interstitial nephritis, and pneumonitis in these patients. Diagnosis starts with ANA, or anti-nuclear antibodies, which will be positive in Sjogren's. ANA isn't specific to Sjogren's, though, since it can be positive in other diseases as well. The specific antibodies to test for are anti-Rho, or SSA, which stands for Sjogren Syndrome Type A antibodies, and anti-LA, or SSB antibodies, for Type B. These antibodies, anti-Rho and anti-LA, are specific but not sensitive, so not every Sjogren's patient will have these antibodies. That's why this can also be a clinical diagnosis. Other tests include rheumatoid factor, or RF, which will be positive in these patients, and a Schirmer test, in which sterile filter paper is placed under the lower eyelid and measured after 5 minutes. A positive test indicates decreased tear production. Management includes artificial tears and pilocarpine. Pilocarpine is a cholinergic medication that increases lacrimation and salivation. Side effects can be remembered with the mnemonic sludge, which typically applies to cholinergic toxicity, but you can use it to remember the side effects of cholinergics as well. Sludge stands for salivation, lacrimation, urination, defecation, GI upset, and emesis. So basically the side effects of cholinergics, like pilocarpine, are fluids leaving the body, as well as bradycardia, blurred vision, or pupil constriction. And another medication option is cevimeline, which is a muscarinic agonist. The next topic is systemic lupus erythematosus, and this is a chronic, multi-organ autoimmune disorder of connective tissues. This is a type 3 hypersensitivity reaction. It's most common in females of childbearing age and can occur as a result of genetics, sun exposure, infections, hormones, specifically estrogen, and some medications. When lupus is a result of meds, it's called drug-induced lupus, and it's characterized by positive antihistone antibodies. Drugs that can cause lupus include procainamide, hydralazine, isoniazid, and quinidine. But it usually resolves when the drugs are stopped, and it's not associated with kidney or CNS damage. So the process that generally leads to lupus starts with an environmental trigger, like sun exposure, which damages cells and causes apoptosis, or programmed cell death. And the damaged cells release nuclear antigens. This is where the genetics component comes in. If the person has genes that reduce their ability to clear these damaged cells and their nuclear antigens, then there are a lot of nuclear antigens hanging out in the blood. Their genetics also cause their immune system to see these nuclear antigens as foreign and form anti-nuclear antibodies, or ANA, that bind to them. They then deposit in various tissues, which causes inflammation. And this is what causes most of the symptoms of lupus. But because lupus can affect any organ system and presents with such a wide variety of symptoms, diagnosis is often difficult. So let's go through symptoms before we get into diagnosis. Lupus has a triad of symptoms to know, and these are joint pain, fever, and a malar butterfly rash, which is a fixed erythematous rash of the cheeks and nose that spares the nasolabial folds. Lupus also presents with fatigue and serositis, which is an inflammation of serous membranes, like the lung pleura or pericardium. It's worth mentioning that lupus can affect any layer of the heart and cause pericarditis, myocarditis, or endocarditis. Endocarditis from lupus presents as Libman-Sachs endocarditis and is characterized by vegetations around the mitral valve. Other symptoms of lupus include a discoid rash, which appears as round or annular erythematous patches on the face and scalp that heal with scarring. And when lupus becomes systemic, it also affects the CNS and cardiovascular systems and can cause glomerular nephritis, retinitis, oral ulcers, and alopecia. Diagnosis of lupus starts with a positive anti-nuclear antibody, or ANA, which is the best initial test since it's very sensitive and found in almost all lupus patients. It's not specific to lupus though, since ANA is seen in other autoimmune diseases. So if it's positive, then more tests are needed. But if it's negative, then we can rule out lupus. Rheumatoid factor will also be positive in lupus, but this test is also not specific. So after a positive ANA, check for anti-double-stranded DNA and anti-Smith antibodies. These tests are specific for lupus, meaning that if they're positive, then the patient definitely has lupus. But they're not sensitive since not all lupus patients will have them, so they can't rule out lupus. Another antibody is anti-phospholipid antibody. This one is less specific since it can be found in other conditions, but it's important to test for because some lupus patients can develop antiphospholipid syndrome, where the antiphospholipid antibodies cause a hypercoagulable state. These patients are prone to blood clots and often end up needing lifelong anticoagulation. Okay, another way to diagnose lupus is to meet 4 of the following 11 criteria: malar butterfly rash, discoid rash, photosensitivity or rashes from sun exposure, mucosal involvement or oral ulcers, serositis like pleuritis or pericarditis, joint arthritis, renal symptoms like proteinuria or glomerular nephritis, neurologic disorders like seizures, hematologic disorders like anemia or thrombocytopenia, a positive ANA, or positive for other antibodies like anti-Smith, anti-dsDNA, and antiphospholipid antibodies. Lupus is generally characterized by periods of flare-ups and periods of remittance. Treatment is aimed at preventing flare-ups or limiting their severity. Sun protection is important to prevent flare-ups, and pulse-dose corticosteroids can be used to reduce the immune response. Hydroxychloroquine can be used for skin lesions, and NSAIDs or acetaminophen can be used for arthritis. In severe disease, consider cytotoxic drugs like methotrexate and cyclophosphamide. The last topic is scleroderma, also called systemic sclerosis. This is a systemic autoimmune connective tissue disorder characterized by thickened skin, lung, heart, kidney, and GI tract. Now, there's also a localized type of scleroderma that only affects the skin, but we're going to go through the systemic type here. Scleroderma literally translates to hardened skin, which is the predominant symptom due to fibrous collagen buildup. Within systemic scleroderma, there are 2 patterns of disease: limited and diffuse. Limited cutaneous systemic sclerosis, also called crest syndrome, is the most common type, and it can be remembered by the mnemonic CREST. C stands for calcinosis cutis, which are calcium deposits that build up underneath the skin. R is for Raynaud's phenomenon. E is for esophageal motility disorder. S is for sclerodactyly or claw hand, in which the tightened skin restricts the range of motion in the hand joints. T is for telangiectasia, and of course the skin symptoms, where the skin appears tight, shiny, and thickened, and this primarily affects the face, neck, extremities distal to the elbows and knees. Overall, limited scleroderma has a better prognosis. Diffuse cutaneous systemic sclerosis involves all of the same features of crest syndrome, plus the skin symptoms involve almost the entire body, plus it affects the internal organs. In the cardiovascular system, it can cause hypertension and coronary artery disease. Within the lungs, it can cause pulmonary hypertension and pulmonary fibrosis. And in the kidneys, it can cause glomerular nephritis and scleroderma renal crisis. Diffuse scleroderma is generally a more severe disease. Diagnosis is made with laboratory studies. ANA will be positive in these patients, but this is not specific because, as we know, ANA is positive in a variety of autoimmune conditions. Anti-centromere antibodies are associated with limited scleroderma or crust syndrome and a better prognosis. Anti-SCL70 antibodies or anti-topoisomerase 1 antibodies are associated with diffuse scleroderma and multiple organ involvement. Treatment includes disease-modifying anti-rheumatic drugs, or DMARDs, and corticosteroids. And that wraps up the Orthopedics and Rheumatology portion of the Internal Medicine EOR Exam Study Guide. If you're listening to these videos in order, the next section is endocrinology, which I'll link below once it's up. If you're listening as these videos roll out, there's a whole lot of EOR content getting uploaded at once. So stay tuned, subscribe to the channel, and thank you so much for listening. Happy studying, and I'll see you in the next video.